My name's Gavine. I'm a sports chiropractor. I work at Performance Health in Newport and Back to Function Chiropractic in the city of Sydney. I will be discussing the use of radial shockwave therapy for the treatment of Achilles tendinopathy. So tendinopathy, the causes, epidemiology, physiology. So causes, repetitive strain, so overuse. You got your typical runners, it's very common in particularly middle-aged men. Being sedentary, so you have your older people or people with disabilities who aren't able-bodied. So if they're not using their ankle and their lower limbs, the tissues adapt to a shortened position and then they form adhesions and become tendinotic. Shortened posterior chain. Are you guys familiar with anatomy trains, Tom Myers stuff? So we got the shortened posterior chain. The tissue adaptation in the Achilles is what leads to tendinopathy. There's also, they've shown some genetic predispositions for tendinopathies. I don't know if you guys have heard of that. They do some DNA testing, and there's a certain gene that people can be tested for, and if they have that gene, they're much more likely to get tendinopathies. Poor diet, and also trauma, and poor lower limb biomechanics, which you guys would be very familiar with, and positive heel shoes, which kind of goes with the shortened posterior chain. So we got the superficial back line here. This is Tom Myers anatomy trains. So you can see the plantar fascia going up into the Achilles, to the gastrocs, to the hamstrings, to the dorsal sacral ligament, up through the erector spinae, up into and finishing up in the occipitalis and frontalis. So someone can actually have an adhesion in their frontalis causing shortening of their Achilles tendon. Yeah? I usually start from the bottom and work my way up, yeah, rather than start at the top. Yeah? So epidemiology, about 2 to 3 per 1,000 people consult GP because of pain in the Achilles region. Elite running athletes, their lifetime is about 52%. Elite level football Achilles injuries account for 2.4% of all injuries. For footballers, Achilles injuries were also found to result in the longest absence from playing. So once they get an injury, this is one of the worst ones they can get because they're off the field for the longest. Okay, physiology. So we got collagen fragmentation. So we get that the collagen changes in the actual tendon from a type 1 collagen to a type 3 collagen. Type 3 collagen is much less elastic, so it's not going to stretch like the type 1 collagen. Also, surgeons say when they're doing surgery on it, instead of the tendon actually being nice and white and glistening like a healthy tendon, it actually appears grayish and like there's some gluey kind of gunk on it. Yeah, so they can tell straight away. And you get change of the orientation of the collagen. So as Dr. So explained, the change in the proteoglycans. The aggrecan is the predominant one. Decreased enzyme activity in the actual tendon. Increased fibroblastic and myofibroblastic cells. And there's absent inflammatory cells. So it's not tendinitis, yeah? Everyone still likes to use the term. It's a bad term, right? Itis infers inflammation. There is no inflammation, okay? They've done that on several tests to show there's no inflammation in the area. Okay, there's no inflammatory cells present in chronic tendinopathy. So they've done biopsies to show that. So with the anti-inflammatories, it helps a bit. They actually don't know why. Dr. So has probably alluded to that a little bit with the, with the ibuprofen, yeah. So it's more they don't really know how it works, because obviously it's not working on the inflammatory cycle, yeah. Condition is a tendinosis, yeah, so. It's a degeneration of the tendon. I always explain that to patients, that it's not just an inflammation. It's actually the physiology, the architecture of your tendon has changed, okay, and that's what we have to return it back to the way it was, okay. And I often use the analogy of it's like metal that rusts, okay? Now, metal can take a long time to rust, just like an Achilles can take a long time to become tendinotic, okay? But just like a piece of metal, I can shine that piece of metal up pretty quickly, yeah? Make it shiny and new again. Same thing with tendinopathy, yeah? So patients tend to get that analogy if you say, and it like metal that rusts, you know, when metal rusts, it kind of expands, all right? Tendinopathy, same thing. You'll get an expansion of the tissue. Particularly with the Achilles, you'll see a thickening of the tissue. It's a real easy way to diagnose and find it. Treatment. So we got the master touch here. What I'm going to show you today.
Which, just to throw in, no difference in clinical outcome from the smart model that we have. Just treat, you know, bells and whistles like the touch screen and stuff. So just,
yeah. It's digital. Yeah. We all like digital these days. All right, so there's a preset on it. It's 2.5 bar, 10 hertz, and 2,500 pulses. You don't have to use that, but it's easy if you just put it in. Yeah, and then you kind of mess around with it. Yeah, so it's important to set the pressure to the level the patient can tolerate. So if you put it at 2.5 bar, which is for the first treatment, that's a bit high. I never start at 2.5. Yeah, I usually start at
1.5.
Yeah, I usually start about 2, and kind of, if I put it on, the person jumps off the table, I turn it down. Yeah, I don't just say suck it up. All right.
That's why I say preset gimmicks are a bit of a, you know, even though we have it on the touchscreen model. That's why I say the smart model, which doesn't have that, because every patient, every indication is different. Start low as a rule of thumb and work your way up.
Mm. So find the most painful areas and work on them, and always ask for feedback, okay, from the patient. So if the patient's sitting there going like that, you're probably going a bit too hard, even if they're saying, I can take it, you know, because you want them to come back, yeah? All right? I always go easy on the first visit, all right, on purpose, because I want them to come back, yeah? So if I kill them and they can't walk for 2 days, then they're probably not going to come back and see me, even if it helped them in the long run, yeah? Treatment frequency, I do depending on the person's availability, 1 to 2 times a week. Twice is the most I do per week. I have some patients, they can't handle twice a week because they're too sore from the previous treatment. And then some of them, I could probably do 3 times, but I don't want to because I know the physiology really can't take it that well. And I know I'll get a good effect with twice a week. So in my experience, this is just on my experience, there's no studies, I fixed most of them in 10 to 20 visits. Like, that's total resolution. They're running a marathon after I'm done with them. Yeah? So that the tissues fully return to how it used to be. Yeah? Or pre.
Are there gaps between 3 to 5, let's say, or do you see them once a week continuously?
Again, that's just, again, either once a week or twice a week. Yeah. It really depends on the chronicity of the condition. You know, I have a patient I'm just finishing up with. He's on his 21st visit, but he's had it for 10 years. So it's well ingrained, and I'm undoing years and years of rust. Yeah? Whereas someone who's only had it for a couple months, 10 visits, they're running a marathon. Yeah? And that's full resolution. That's not, I feel better, it's perfect. Yeah? Research shows the effects are improved when combined with eccentrics. So Dr. So was showing I call them heel drops. Yeah. So I get people to do them twice a day, 2 sets of 15 each side. Even if one side doesn't have tendinopathy, I still get them to do it. Because usually there's the starting stages of tendinopathy. Yeah.
No matter where the pain is in the Achilles?
Yeah. Yeah. Again, I'm usually focused on lengthening the tissue. I'm focused on the myofascial, the trains, and so I'm checking dorsiflexion. If their dorsiflexion sucks, I get them to do the eccentrics. So effects, so this is the effects of the Shockwave. So tissue repair, tissue regeneration. We get decrease in substance P, which is the pain-sensitive substance. Neovascularization, so we get new formation of vascular cells, like capillary beds and such. We get a release of angiogenic and growth proliferating factors, so that helps again with the vascularization in the area, which increases blood supply. So what Roland was speaking of, so even after the treatment, the physiology you're changing in the patient occurs for weeks and months later. What did you say? 3?
Yeah, two and a half to 3 months.
Yeah, 2.5 to 3 months. Okay.
And I can actually vouch for that because I've rolled my ankle numerous times when I was younger and recently, and you know, Adam did about 5 treatments on me, and definitely even like 2.5 to 3 months down the track, really good. And I've been slack on my stretching, and you know, I still do my crazy things that I do, and yeah, it's come back a little bit. So it's like, you know, yeah, definitely.
All right, so these are kind of the 3 pillars of healing that I talk to my patients about to get the condition better or get the best results. So get the patient to avoid or at least minimize the activities and postures that aggravate the condition. All right, so if someone's sitting at a desk all day in this position, that's gonna not be a good thing, all right? The problem's gonna probably come back eventually if they're doing that for 8 to 10 hours a day, every day, or running, so we're talking about capacity, and you know, if someone's training, they're doing 50 kilometers a week, you know, they might not be able to do that for a little while until I get it better. So I always talk to them, and I'm sure you guys all have dealt with runners, how psycho they are, and they don't ever, like, they'd rather die than stop running. Yeah? Yeah? I hear laughter, so everyone's experienced it. So you got to kind of bargain with them, and you just say, look, how about we cut it down to 3 times a week instead of 5 times a week? You know, they still won't like that, but if you say to them, look, this is going to help you get better faster. If you run 5 times a week, you can, but you're actually going to slow down the process, and instead of 10 visits, it's going to take me 20 visits. I'm happy with that because I make more money. Yeah? He's going to see me for 20 visits instead of 10. But I'm very upfront with people. I tell them, look, if you want to get this better, you got to play a part in this as well, okay? And some will say, yeah, I don't care. Some will get on board though, yeah? So get the patient to start incorporating activities and postures that improve. So again, we're talking about stop doing the bad things, start doing good things, okay? So the opposite of the patient sitting at their desk all day in the plantar flex position is you get them to put something under their feet and put them in a dorsiflex position all day, all right? So you're remedying the problem, yeah? Or you can get them to do the eccentric stretches, yeah? You got to be consistent with the treatment. So if I say you need to come for 10 visits and you come for 3 visits and then you miss for the next 3 weeks and you come back for another 2 and then you miss another week, you know, you got to be consistent. If you want to get this right, you got to keep on it, okay? Because otherwise it's 2 steps forward, 1 step back, yeah? I want to go 2 forward, 2 forward, 2 forward, 2 forward until it's finished. So an ounce of prevention is worth a pound of cure. So things we can do to reduce the risk. So you want to get patients to move. Again, that's talking about like the sedentary people, the desk workers, you know, getting them up, walking around, increasing the blood flow to the areas. Proper hydration. A lot of people don't realize they're not properly hydrated. I always tell people if your urine's yellow, you're dehydrated. It's an easy way to monitor it. Healthy anti-inflammatory diet. So certain things you want to avoid in the diet that are pro-inflammatory, certain things that we want to incorporate, omega-3s and such to help with that. Avoiding things like nightshades are pro-inflammatory. And exercise, not too much, not too little, just the right amount. And fixing poor biomechanics, which you guys do all day. Yeah, so definitely want to look at that. There we go. Questions? I got a little joke there too. All right. Do you guys want to do questions now or after we do the demos? Do the demo stuff? Okay. Yeah, we'll get onto it then.
And I've actually met Adam. He works with an orthopedic surgeon, so he actually uses it on IT bands, like on post-op patients, which is quite interesting. If there's maybe a touch, because you guys could do IT bands, couldn't you? Lower limb.
So I always just go on either side of the Achilles to feel for the thickness and for lumps and bumps and stuff. junk. I call it junk. Yeah, right here he sucks. Doesn't like that at all there, does he? Yeah. So that's what I'm looking for, the nasty bits, and I just put a little dab on. Do you guys all have a machine, or have some of you? Yeah. Who doesn't have a machine or hasn't ever used it? Okay. So we'll try and get everyone to have a bit of a go. But we'll have
the wake up for all this.
How many pulses maximum? 4,000, right?
It depends on what the spot. Like if I hold it in one spot,
Then of course.
We say 6,000 into the area, into the body in one session.
Yeah.
But you would definitely wouldn't want to do like 6 into one. Smaller.
No.
Yeah. So if you've got like hamstrings or like when you're doing those IT bands on bilateral IT bands, you're doing what, 6 per side, aren't you? Roughly 5?
Oh yeah, because it's a huge area you're covering. So it's
6,000 per side.
yeah, it's a huge area. So
You're doing it like a
so.
And you hold the grip like so as opposed to the pistol grip.
Yeah, you can do anything you want. I find when I hold it like this,
It gives you more control.
I can actually feel what's happening in the tissue. I can feel when I'm on the lumpy bit. Okay? So I'm doing a lot of feeling with the probe myself. Yeah. So for him, I can feel right here. Right there's a lump. Because when I go over it, I slip over it, and when I come back this way, I slip that way. So you can either just hold it. Yeah, and I play with the ankle as well. I'll usually put them in a dorsiflex position. Yeah. Again, because I'm thinking I want to lengthen. Yeah, it's all right. There's one. Okay. Just relax. There we go.
It slides down a little bit more.
Yeah, come down a bit more. Oh, there we go. So it's just in here. Okay. So if you guys want to kind of make a line and just have a quick feel here, and you'll. So that's one way of doing it, is just holding the one spot. I tend to. I think Roland said I'm the only one who does it, but I find what works well is I almost iron, like I'm ironing. Yeah, because I'm finding the lumps and bumps, and I'm view it like I'm ironing a shirt. I'm trying to get the wrinkles out of the tendon, yeah? And I just keep going over it until eventually what will actually happen is you'll start to feel the probe will glide through way faster. So at first it'll be like slow, and there's a restriction. Yeah, there's a resistance. Yeah, it's like drag. Once it's gone, you'll just go like that. Okay, that's when I know it's done. Okay, so I don't really focus so much on the pulses. I focus on what I feel.
It's the fascial tension, isn't it?
It's just fascian, adhesions, whatever, scar tissue, whatever it is. Okay, so you guys want to come here? So this, I'll show you the ironing that I do. So I just kind of back and forth over that spot. You still do. Yeah, you still do. Yeah.
Like if you would find a spot while you're doing that, if you find one spot which is really bad, then you would stay there for longer.
Yeah, well, you kind of play around with it. There's no hard and fast rules with it, you know, and you'll play with it, and you'll find that sometimes that works on certain patients, and sometimes just going back and forth works best. Yeah. It's really dependent on the patient, yeah, and what kind of response you get. Okay, so
I've seen some therapists use it almost like a diagnostic tool, because when they use it, then they find the spot, you know, like which is really painful, and then they work more on that area. So
yeah. Okay, so come around, guys.
I'll definitely let you know when you found the spot.
Absolutely.
Yeah.
So don't be scared. Have a go. And you feel, so if you slide back and forth, you'll feel almost like a lump. Yeah, right where I put the pen mark.
Take that.
Is that painful at the moment?
Okay.
Yeah, but it's a good pain. Like you got to be in patients. I find I've treated probably 100 patients. I do in services, and you know, I treat as much as more as anyone in this room. Actually, though I'm not qualified. And while patients are initially thrown, they intuitively feel it's good. I think it's a good pain. Yeah.
It's like a massage.
Yeah. Deep tissue massage.
Yeah. It's bad, but you know you want it. Yeah. But
It's so bad, but you know you want it.
So you just press that. I hold it like that. Yeah, like that.
oh, got it.
Yeah. And then you just push in. So you want to get right. There's a groove. It'll kind of sit in the groove. And if you slide past that line, you'll feel a lump. You feel the lump? Sometimes you got to push in a little bit harder. Feel the lump? Yeah.
Oh, yeah, maybe.
Yeah. And then I always work medial and lateral.
This will like save you
The medial aspect of the Achilles is always worse. Like I've seen one person maybe in 3 years that was worse on the lateral side. To hold, you'll slip. It slips all the time. And two, what they've shown is predominantly the tendinotic portion of the Achilles tends to be on the anterior portion of the Achilles rather than on the posterior. Yeah. It's bad right here. Hard enough, because so I'm depressing that to the first line. So I can push harder, but I don't have to, like, that's gonna hurt. So I just press hard enough. I kind of do it so that I can feel. I do everything by feel. Yeah, so I'm feeling for the bad spot. On that, can you feel it there? Lumpy? If you try and slide, you feel when you try and slide there, it slows down? Yeah. Yeah. Could you feel that? Yeah. You can feel that. Yeah. Hi, thanks for tuning in today. We hope you learned something from our discussion and can take something away from it. If you have any further questions or comments, please direct them to the emails located in the credits.